Para-Para-Paraphymosis. What is a paraphimosis? They're quite uncommon, but perhaps you've seen one during your ward round, or perhaps in the emergency department. It's one of the few things a urologist will wake up for in the middle of the night during his busy, hectic on-call shift. Phimosis, paraphimosis. They're not quite the same. Phimosis occurs when the foreskin is unretracted, but is a little tight. A paraphimosis, meanwhile, also known as capistration, occurs when the foreskin is retracted below the glans penis and is subsequently unable to return to its unretracted position. This may prevent lymphatic drainage, followed by venous drainage, followed by arterial drainage from the glans penis. This only occurs in uncircumcised men, but tourniquet effects can mimic the presentation in the circumcised penis. Why does paraphimosis occur? Usually it's not your fault. Maybe a silly junior doctor left the foreskin retracted after performing catheterization. Please don't do this. But sometimes it is. Vigorous sexual activity or penile piercing may predispose. Pre-existing inflammation or phimosis can also predispose to a paraphimosis. What are the signs and symptoms of paraphimosis? In the early stages, he may complain of swelling, pain, erythema around his glands and foreskin. But as it progresses, there may be difficulty to pass urine, pallor and cyanosis, gangrene, and autoamputation. Ouch. But don't worry, help is at hand. Follow these simple steps to prevent these dreadful consequences and save a lifetime of psychosocial complications. Step 1. Manual reduction. You could try randomly pulling on the foreskin, but there is a technique to this. Firstly, remove any foreign bodies or constricting bands. Pushing on the meatus with your thumbs to reduce the swelling while simultaneously pulling back on the foreskin with your fingers can be effective. Failing this, another technique is to apply circumferential pressure around the glands before attempting to retract the foreskin. A compression bandage, such as using a swab and elastic bands around the glands, can mimic this if you need to have a coffee in the meantime. Don't give up too early. It can take a while, between 5 to 10 minutes. But you can reduce this time by using adjuncts, such as ice, and creating an osmotic gradient, such as with 50% dextrose. Let's repeat that. Remove any constricting bands, push on the meatus, pull on the prepuce. Circumferential pressure for 5 to 10 minutes. Ice, osmotic gradients, and compression bandages can help. Warning. Step 1 is known to be quite painful. Local anaesthesia gels can be useful, but they do take a while to work. If more pain control is needed, there are 2 main ways to do it. Probably the easiest way is a subcutaneous ring block by circumferentially injecting 1% lidocaine around the base of the penis. Alternatively, a penile nerve block by directing anaesthetic towards the dorsal penile nerves can be effective. Do not mix the anaesthetic with adrenaline. And remember, keep the patient nil by mouth in the meantime. They may need to go to theatre. Step 2. If step 1 has failed, you will probably need a urologist to hand. They may recommend more invasive measures, such as injecting hyaluronidase into the constricting band of foreskin, which helps disperse the edema, or even blood aspiration from the glands of the penis. Alternatively, they may recommend the Scottish method of stabbing the constricting band of foreskin up to 20 times with a needle, and subsequently decompressing the foreskin. Step 3. Surgery. You've terrorised the penis, poking and prodding it to little avail. There may already be onset of necrosis. In any case, dorsal slit incision will usually work where other methods have failed. The constricting band of foreskin is simply cut at the 12 pm position using a 1 to 2 cm slit. Allowing the edema to flow past the obstruction, reduction may now take place. The foreskin is sutured and peace is restored. Step 4. Aftercare. The patient should not retract the foreskin for a week and should not reinsert any piercings. Local antibiotic cream may be needed if tears were sustained during reduction, and antibiotics if there was a predisposing infection. Circumcision is usually not needed, but referral to a urologist is usually sensible for consideration of such, particularly if the paraphimosis is recurrent or secondary to a chronic cause, such as a phimosis. Step 5. Wave goodbye to your patient and wish them well. If you have followed this presentation correctly, you may just save a penis. But in case you have nodded off to a GCS of 13, wondering what you will be having for lunch, what is on the television tonight, or mentally reciting passages from the memoirs of William Osler, do take note of the following case-based discussion, which summarises the topic.
Yeah, it's likes for life. Big it up for the FY1s. Yeah, oh, yeah, oh. Case-based discussion, 2014.
Wrong wagon.
Let me lay down this case-based discussion. Might seem a little crude, but there'll be repercussions if you fail to revise and recognise the signs of this emergency condition. So you sentence you 25-year-old staring at you asking what to do. Doctor, I know this is really silly, but there's a problem with my willy. You start to unravel the mystery and take a little bit of a history. Let's call him PJ, he's a DJ from the farm, good looking with a yummy honey that he met in the bar. The next day, things are feeling rather strange. The shape of his penis is all deranged. Torn at the glands and severe pain, he couldn't pull the foreskin back again. He's having difficulty when he tries to pee. The base is flaccid, but the glans is sturdy. Usually happens after being badly catheterized. Never happens when the penis is circumcised. Altimeters for the kilometers, can't pull the foreskin back. It's a Paraphimosis. Will you save the day? Can you pull it the right way? Paraphimosis. Don't mean to sound so serious, but pale genitalia can turn gangrenous. Better act quick or it's gonna turn sick. Put a little bit of lube on a disco stick. Remove any catheter ice when trying to reduce. Pushing the VHS, pulling them a piece. 50% dextrose on a swab. Osmosis removes any fluid from your knob. Hyaluronase blood your aspiration. Tell urology about this castration. If we can't fix it manually, the only other option is surgery. A dorsal slit is usually fine. Circumcision's usually the very last line. If you're gonna put anesthetic in, make sure you don't mix with adrenaline. A 1-2-2 cm slit in the 12 pm position. Cut the band and understand.